Buenos dias. Thank you for having me today. So I have a big topic to cover, the best of American College of Gastroenterology. So clearly would need more than 20 minutes. So I'm going to try to be very succinct and give you the best of what's happened at ACG this last year. So the outline of this talk will be to outline the highlights of the presidential plenary abstracts from last year's ACG. Those were from October 2024. There were 10 abstracts presented. One I omitted because it was very US-centric and I felt like it wouldn't apply as well to this audience. So let's talk and go through each of these 9 studies and hopefully have some important take-home points for your practice. So the first study looked at the efficacy, safety, and tolerability of Movie Prep, a 2-liter prep, compared to Go Lightly, a 4-liter prep, for bowel prep in patients in the hospital requiring colonoscopy. So we all know that inadequate bowel preparation affects 1/3 to 1/2 of inpatient colonoscopies. We know that low volume prep, less than 2 liters or equal to 2 liters, is preferred by many patients, but yet standard is typically to give patients in the hospital a 4-liter prep. The question, though, is low volume prep non-inferior to high volume prep? So this study design was a single-blind, multi-site, randomized control trial done out of Yale New Haven. There were over 500 patients in the hospital who required colonoscopy, and they were randomized to either 2-liter prep or 4-liter prep. The primary outcome of the study was adequate bowel prep based on a standardized prep system. And their secondary outcomes looked at safety, electrolyte abnormalities, patient tolerability, length of stay, the time and duration of the colonoscopy, and successful cecal intubation. So here are the key findings. In terms of efficacy, you can see that a 2-liter prep was deemed non-inferior to a 4-liter prep. The rate difference was only 2%, so not significant. In terms of safety, there was no significant differences in electrolyte abnormalities or acute kidney injury. And as you'd expect, the tolerability of the 2-liter prep was rated far easier by patients compared to the 4-liter prep, and they were more willing to tolerate future colonoscopies. In terms of the secondary outcomes, there was no difference in length of stay, cecal intubation rate, or any of the other secondary outcomes of interest. So the conclusion from this study is that a 2-liter prep is non-inferior to a 4-liter prep in hospitalized patients requiring colonoscopy. We know that there's better patient-reported tolerability, and there's no increase in safety risks. And we know that there are more studies needed, obviously, to look at cost effectiveness and other factors in terms of the indication for that colonoscopy. The next study is looking at a topic that we just heard a lot about regarding diarrhea and fecal incontinence. So this was a study looking comparatively at biofeedback versus injection therapy with a dextroamer hyaluronate for fecal incontinence. So again, the background here, we know that fecal incontinence is very common, affects in nearly 10% of women, having significant impact on quality of life. We know that typical therapies include diet, medications, perhaps biofeedback, injection therapy, or even sacral nerve stimulation. There's been very little, though, in terms of limited head-to-head comparison of biofeedback compared to injection therapy. So that's what this study was looking to do, compare the effectiveness and safety of those two, biofeedback and injection therapy, in patients with fecal incontinence who failed enhanced medical therapy. So this study design, again, was a multi-center randomized control study. It was done out of Mayo Clinic with a number of collaborators, and there was over 200 patients who were considered to have moderate fecal incontinence who had failed standardized therapy. They were all adult patients with prolonged symptoms. You can see that all of those patients who failed typical therapy were randomized into biofeedback or injection therapy. And you can see their primary outcome was a 75% reduction in weekly episodes of fecal incontinence. Secondary outcome was a 50% or more reduction, as well as quality of life indicators. So their key findings, when you looked at the primary outcome, again, a 75% reduction, you can see there was no difference between the injection therapy and biofeedback when looking at an intention to treat design. The same goes true with the secondary outcomes. You can see when looking at a greater than 50% reduction in fecal incontinence, as well as looking at all of the quality of life indicators, both treatment arms were equivalent. The quality of life impact, both arms, study arms, felt that they improved their quality of life similarly, and there was no major safety concerns reported in either arm, and they were both well tolerated. So the conclusions from this study is that biofeedback and injection therapy are equally effective for fecal incontinence after failed conservative therapy. And so both of these should be considered viable options that you recommend to patients. The question that I think many of us raised when we heard this presentation is, well, what's the benefit perhaps with combined therapy? And I think that's a study that needs to continue to be answered. The next study is changing directions a little bit and thinking about the risk of colon cancer in those with primary sclerosing cholangitis. So this study was PSC in the absence of inflammatory bowel disease and looking at the risk of colorectal cancer. So we know that colorectal cancer is very common. It's the second most cause of cancer death in the US, and it's still a very high cancer cause of mortality worldwide. We know that inflammatory bowel disease, more so ulcerative colitis, increases that risk of colorectal cancer. We also know that primary sclerosing cholangitis is a well-known risk factor for colorectal cancer in the setting of inflammatory bowel disease. And in fact, our current guidelines would suggest annual colonoscopy in those who have combined PSC and IBD. The question, though, is it has been unclear if PSC alone increases the risk of colorectal cancer. So the aim of this study was to evaluate the risk of colorectal cancer in those with PSC alone versus those with PSC plus IBD versus those who are in control without either one of those. So the study design here was a retrospective cohort using a very large database of over 115 million patients. Within that database, there were over 12,000 patients with primary sclerosing cholangitis from 65 institutions across the United States. You can see the inclusion criteria were adults with PSC and IBD, and then they had a similarly matched control group. So the key findings here were very interesting in that primary sclerosing cholangitis alone increases the risk of colorectal cancer with a hazard ratio of 2.89, which was significant. And of that group, males had a higher risk in that group compared to women. Not surprising, those with PSC plus IBD had the highest risk of colorectal cancer with a hazard ratio of 6.51. And both men and women were at increased risk, women, interestingly, being of higher risk between those two. And then not surprising, we know that the combination of PSC plus IBD was greater than PSC alone. And again, this is true for both men and women, but particularly, again, a propensity to be at higher risk in women. So this is a really important study, and it concludes a few interesting things. One, we know now that PSC should be viewed as an independent risk factor for colorectal cancer, even without inflammatory bowel disease. And guidelines really should consider colorectal cancer screening in those with PSC, not just those with IBD. Again, there are limitations of any study, and this was a retrospective design and limited data on colorectal outcome in the setting of other diagnoses. But again, it's important to think about your colorectal cancer risk in all of your PSC patients, regardless of IBD or not. This was another very interesting study that will change the way that I practice in the inpatient setting where I see a lot of patients with encephalopathy. So this was a study that looked at rifaximin as monotherapy being more effective than lactulose monotherapy for reducing the risk of overt encephalopathy recurrence and all-cause mortality. So let's talk about the background. We know that lactulose has been considered standard for secondary overt hepatic encephalopathy prophylaxis after an initial episode of encephalopathy. We know that rifaximin is typically added on in patients who either are still having encephalopathy or who have intolerance to lactulose. And we know that lactulose adherence is hard. We know that there are GI side effects, patients complain about the taste, and it can be hard for them to navigate the dosing challenges with lactulose. So the aim of this study was to compare the efficacy and safety of rifaximin monotherapy versus lactulose monotherapy for reducing that risk of encephalopathy recurrence in patients with known cirrhosis who have a history of encephalopathy. So the study design here was a post hoc analysis of 2 randomized controlled trials. They looked at adult patients with cirrhosis who had prior encephalopathy treated with either rifaximin 550 milligrams twice daily or lactulose monotherapy for 6 months. Their primary endpoint was the time to first breakthrough of encephalopathy. And you can see their inclusion criteria: adult patients, 2 or more episodes of encephalopathy. Their encephalopathy at the time of enrollment had to be in remission, and they had MELD scores of less than or equal to 25. So their key findings show that in terms of encephalopathy recurrence, you can see that rifaximin had only a 23% recurrence compared to lactulose at 49%, so a significant reduction. And in fact, the number needed to treat, it only required 4 patients to be treated with rifaximin to prevent 1 episode of encephalopathy. What was also interesting is there was a reduction in mortality. So you can see those in the rifaximin group had a mortality of 1.6% compared to 4.8% in the lactulose group. And again, when you look at a number needed to treat, you need to treat 19 patients with rifaximin to prevent 1 death. We also know that combination therapy with rifaximin plus lactulose versus lactulose alone was also beneficial for all of those outcomes. And in terms of safety, rifaximin had fewer adverse events and lower discontinuation rates. And these 2 graphics show those same results in graphical detail. The top graph looks at the percent of patients over time without breakthrough encephalopathy. So you can see the rifaximin group clearly did better. And same with the mortality. And even though that looks like a small difference, that was statistically significant. So in conclusion, rifaximin monotherapy significantly reduces encephalopathy recurrence and mortality. Rifaximin is well tolerated and may be appropriate management for select patient populations. The next study is also very interesting and will also, again, change the way that I practice my inpatient care of patients with cirrhosis and variceal bleeding. So this was a comparative outcome study based on the duration of vasoconstrictor therapy after endoscopic variceal ligation in those with acute variceal bleeding. And this was a systematic review and network meta-analysis. So again, we know that variceal bleeding has very high morbidity and mortality, and we know that endoscopic variceal ligation is preferred over sclerotherapy. We also know that vasoconstrictors have traditionally been used for 5 days post-band ligation, and that has what has been kind of the cornerstone of what we have done, even though there are other studies that suggest a range from 2 to 5 days may be acceptable. But we know that prolonged vasoconstrictor use may increase adverse events and certainly increases hospital stay. So the aim of this study was to compare the outcomes of vasoconstrictor therapy after band ligation based on duration of therapy. So again, this was a systematic review and network meta-analysis of 11 randomized controlled trials that were included in the final analysis. And I will note these were all Asian studies. You can see they had various groups based on the duration of vasoconstrictor therapy. Group one was very short, less than or equal to 24 hours of vasoconstrictor. Group two was short, basically 1 to 3 days of vasoconstrictor therapy. And group three was considered more standardized therapy, 3 to 5 days of vasoconstrictor. The outcomes they looked at were rebleeding, and then they looked at both 5-day and 30-day mortality, and then they looked at this SUCRA, which was surface under the cumulative rank area. We're not going to go into great detail about that statistical method, but it was helpful in coming to their conclusions. That SUCRA are all the graphs above, which I'll summarize their key findings below. Basically, they found no significant difference in rebleeding or 5-day or 30-day mortality across any of the vasoconstrictor durations between group 1 and group 2 compared to group 3, again, group 3 being a traditional standard therapy. And when they looked at that SUCRA analysis, you can see they had some slight changes in terms of bleeding or mortality based on the various groups. But overall, the 24-hour vasoconstrictor duration ranked the highest overall, which is really important and is a paradigm change for what we do currently. So the conclusion here is that shorter vasoconstrictor duration post-endoscopic variceal band ligation are as effective as standard durations. This may allow early discontinuation to reduce hospital stay and adverse events, and it really, again, supports re-evaluation of our current guidelines. The next study was looking at artificial intelligence-driven EUS for the detection of pancreatic lesions. So we know that pancreatic cystic lesions and pancreatic solid lesions are very commonly found incidentally, but we have a difficult time differentiating those with higher malignant potential versus those with less malignant potential. We also know that an accurate diagnosis is critical, particularly for those pancreatic cystic lesions to know if they're mucinous or not, as well as those solid lesions to know if they're pancreatic ductal adenocarcinoma or not. So this study design was a multi-center retrospective study across 4 hospitals in Europe and the United States. They looked at nearly 400 endoscopic ultrasound procedures with 126,000 images, and they used artificial intelligence and a convolutional network to really look at those images and evaluate them. And what they really did is train this model to help differentiate between pancreatic cystic lesions that were mucinous versus non-mucinous, and solid lesions that were ductal adenocarcinoma versus neuroendocrine. So again, you can see on the top was looking at the cystic lesion, mucinous versus non-mucinous. And you can see the sensitivity, specificity, and accuracy of this AI-generated tool was very effective. You can see in the bottom graph looking at ductal adenocarcinoma versus neuroendocrine tumor. Again, the sensitivity for the ductal adenocarcinoma was quite high, and the accuracy was greater than 90%. So again, for cystic lesion, the sensitivity and specificity was greater than 98% for mucinous lesions, non-mucinous lesions, and normal pancreas, and determining the difference between those 3. And we know that for those solid lesions, again, very good sensitivity for ductal adenocarcinoma with a high accuracy rate. So the conclusion here is this is the first worldwide network analysis capable of real-time detection of differentiated of both solid and cystic pancreatic lesions and a really high diagnostic accuracy in terms of mucinous, non-mucinous, or ductal adenocarcinoma versus neuroendocrine. And so obviously lots of potential future work for prospective additional studies to validate this. All right, as we start to wrap up, this study looked at the correlation of small bowel lesions using cross-sectional imaging versus small intestinal contrast ultrasound in the setting of Crohn's disease. So we know that cross-sectional imaging, CT enterography or MR enterography, and intestinal ultrasound are used to evaluate small bowel Crohn's disease. Past studies have shown cross-sectional imaging to be superior to intestinal ultrasound, but those studies did not include contrast small bowel ultrasound. And this may prove to have improved diagnostic accuracy, but we know is underutilized in practice. So the goal of this study was to look at the primary outcome of the accuracy of CT enterography or MR enterography versus intestinal ultrasound for the presence and extent of small bowel disease of Crohn's. Also then looking at wall thickness, length of disease, and complications. So again, a little bit of a complicated study design, but what they did is they paired a validating study of patients with known Crohn's disease, and these patients underwent cross-sectional imaging, intestinal ultrasound, as well as contrast-induced ultrasound as well. What they found in terms of the disease presence is that using intestinal ultrasound with contrast had very high sensitivity, very high specificity for detecting small bowel Crohn's disease. You can see that contrast-induced ultrasound was more accurate, not by much, but by a few percent than traditional ultrasound. We also know that contrast ultrasound outperformed traditional ultrasound in detecting strictures and fistulas. But we know that CT enterography and MR enterography often led to more changes in therapy just because you get more of an inclusive look of the entire abdomen. So the conclusions here are that intestinal ultrasound are effective tools for monitoring small bowel Crohn's disease, but that contrast-induced ultrasound enhances detection of the disease extent, and looking for complications. But we still note that there's an important role for cross-sectional imaging to look for other aspects of disease, including that which may not be well visualized by ultrasound. All right, and this is the final study. This is looking at heartburn frequency and symptoms and improvement rates of treated when switching from daily on-demand vonoprazan treatment for patients with non-erosive reflux. So we know that vonoprazan is a potassium-competitive acid blocker, or PCAB. These offer very rapid, on-demand, very durable acid suppression after a single dose, and the benefit for patients is it's food independent, so it does not need to be dosed before meals like we do with PPI therapy. So this has been FDA approved for daily use in non-erosive GERD. The aim of this study was to evaluate the frequency of heartburn episodes when switching from on-demand treatment after achieving control to on-demand therapy, and then the rate of symptom improvement of treated episodes. So again, this was a post hoc analysis. Patients were transitioned from a 4-week daily vonoprazan to a 6-week period where they either got placebo or one of 3 different doses of the study drug that was taken only on demand. And they tracked their heartburn episodes and severity. So this diagram above, again, highlights the methodology. You can see that in the white box, those are screening without any therapy, and you can see that heartburn control improved from 16% up to almost 83% with daily PCAB therapy. After those 6 weeks, you can see in those colored boxes, in gray is placebo. The other 3 colors are 3 escalating doses of the study drug, and you can see all of them brought great relief when taken on demand. So you can see that really there was consistency in terms of maintaining high control of heartburn-free days once you have disease control or symptoms controlled by switching to on-demand therapy. So their conclusions is this PCAB specifically showed promise as an effective on-demand therapy for NERD after achieving symptom control with daily therapy. This provides rapid symptom relief and sustained control. And obviously, there's a lot of additional study with these medications and how we can use them effectively in our toolbox for reflux disease. So I want to thank you for your time and attention, and I hope you have a great rest of the meeting. Mm-hmm.